Hello, I'm Irena Papadopoulos, and in the next few minutes I would like to give you an introduction to the Papadopoulos Tilki and Taylor model for transcultural nursing and cultural competence. But I want to start by saying a few things about compassion, which many of us and many members of the public will view nursing as the embodiment of compassion. Compassion, in my view, is the essence of all caring professions and therefore imperative for healthcare education and its many models of learning. Compassion underpins the Papadopoulos Tilki and Taylor model of cultural competence. The Greek philosopher Aristotle lists compassion as one of the 5 virtues that define our characters and guide our actions. What is cultural competence? 10 years ago, I defined cultural competence as the capacity to provide effective health care, taking into consideration people's cultural beliefs, behaviors, and needs. We all use the term effective to encompass many things such as appropriate, acceptable, compassionate, giving the desired results, and so on. But all these messages are hidden in this all-encompassing term. So today, I want to define cultural competence as the capacity to provide effective and compassionate health care, taking into consideration people's cultural beliefs, behaviors, and needs. Why courage? A culturally competent health professional is one that possesses the virtue of compassion, but importantly also, and always according to Aristotle, the virtue of courage. Courage to challenge acceptable norms and practices which harm, discriminate, or disadvantage people in our care. One of the most frequent criticisms I hear about cultural competence is that it advocates that nurses and other health professionals must go along with people's wishes and practices because they are part of their culture. Health professionals express frustration with this and have told me that sometimes they're frightened to challenge their clients because they fear that either the client or their colleagues may accuse them of being racist. In my view, this is the result of the early writings on cultural competence, which emanated from anthropologists who, whilst correctly emphasizing the importance of culture, neglected to highlight the importance of practical wisdom, the fact that cultures are not static, and in a world where 15,000 tribes are communicating with each other, their differences will sometimes collide. If we accept every cultural practice without question, then we accept that everything is relative and there are no universal human values. Therefore, practices such as those which oppress women should be accepted as the cultural practices of specific groups. This is not the stance I take, and my version of cultural competence requires us to be reflexive, ethical, and to have the courage to challenge, whilst knowing how to wisely balance the risks which come with the challenging. Why cultural competence? I should not need to labour this point too much, as most nurses and other health professionals agree that being culturally competent is important. However, when it comes to taking real action in order to apply this through learning and practicing, we can be confronted with a number of barriers which beg the question, do we really believe that cultural competence is important? 30 years ago, when I started talking to colleagues about the need to include sessions in the curriculum about the relevance to nurses of the cultural backgrounds of the people they cared for, or suggesting the need to discuss cultural beliefs and customs, their answer was that there was not enough space in the curriculum to do this, and in any case, the students were being taught the holistic approach to nursing, which meant that they should view each patient as an individual and respond to their individual needs. It has to be said that in the last 30 years, we have also witnessed the enlargement of the European Union, the effects of globalization, numerous national and international conflicts, major natural disasters and economic crises, as well as the power of the mobile phone and social media such as Facebook and Twitter, all of which have made the provision of culturally competent care a legal, ethical, and moral imperative. And what about human rights? One can easily find international conventions and European legislations which are based on human rights, and I am sure you will agree that most professional codes of practice are also underpinned by human rights. So how does the Papadopoulos Tilki and Taylor model of transcultural health and cultural competence look like? As you can see, the model consists of 4 main constructs. A conceptual map is provided for each stage as a suggestion of what can be addressed by teachers, curriculum planners, or individual lifelong learners. Other concepts can, of course, be added to suit the type and level of students and learning. The first stage in the model is cultural awareness, which begins with an examination of our personal values and beliefs. Spending a little time thinking about our own cultural background will make us realize what values we hold and why. Hopefully, we will discover values, attitudes, and beliefs which are hidden deep into our subconsciousness, but which could surface when we are stressed, and demonstrate that, like all human beings, we too can stereotype and be ethnocentric. This self-reflection will help us prepare when such events happen. Spending time to find out where our patients come from, why they left their country, what values they hold, will make us realize that even though all human beings have much in common, our small but subtle differences are important, as they're the ones which define our uniqueness and our individuality. Knowledge which helps us develop understanding of issues related to vulnerable and often marginalized people, as people from minority cultures often are, could be gained from almost all other disciplines, as well as from meaningful contact with ordinary people from different cultural groups. It is not about learning and memorizing all you can about the customs and rituals of as many cultural groups as you can, even though there is a place for some of this specific knowledge. The Papadopoulos Tilki and Taylor model emphasize the importance of developing culture-generic knowledge, which can then be applied sensitively to extract the culture specifics relevant to each patient. But the most pressing health issue of our time is that of structural health inequalities, and as health professionals we cannot call ourselves culturally competent if we do not concern ourselves with this crucial socio-cultural and political phenomenon. You can clearly now see that the Papadopoulos Tilki and Taylor model of cultural competence puts equal emphasis on both societal structures and people's cultures. An important element in achieving cultural sensitivity is how professionals view people in their care. I believe that unless clients are considered true partners, culturally sensitive care is not being achieved. Because if we do not consider them as true partners, we risk using our professional power in an oppressive way. Equal partnerships involve trust, acceptance, respect, as well as facilitation and negotiation. Key factor in achieving the elements of cultural sensitivity is learning to ask the right questions. Having the necessary awareness and culture-generic knowledge will enable us to anticipate needs and ask questions with the right content, thus minimizing the risk of misunderstandings. Each one of us, whether a student, a practitioner, a teacher, a manager, has to take responsibility for trying to develop compassionate, trusting, culturally sensitive relations with all our patients. How might we do this? First, we need to show our patients that we recognize their pain and anxiety and that we care. We don't need to speak the same language to be able to do this. A gentle smile, acknowledge their presence, will make them feel wanted and cared for. And so to the last and all-encompassing construct, that of cultural competence. The achievement of cultural competence requires the synthesis and application of previously gained awareness, knowledge, and sensitivity. Focus is given to practical skills such as assessment of needs, clinical diagnosis, and other caring skills. A most important component of this stage is the ability to recognize and challenge racism and other forms of discrimination and oppressive practice. But as we noted earlier, the act of challenging requires courage. However, courage without wisdom is dangerous for both the person who is committing the unwise courage and the persons for whom this is committed. Gaining the wisdom to recognize unfairness and to challenge it effectively is a virtue we must learn in similar ways as those we have already discussed in relation to compassion. A good way to assess and plan culturally competent care is by following the principles in LEARN as proposed by Berlin and Fuchs in 1982. L stands for listening to the patient's perception of his or her problem. E stands for explaining your perception of the problem. A is acknowledging the similarities and differences between the two. R is making recommendations which must involve the patient's significant others unless they request otherwise. And N is negotiating the treatment plan, which incorporates the relevant aspects of the patient's culture as well as her wishes and those of the significant others. So what are my main messages? My first one is that culturally competent care is no longer an option, but a must-do. My second is that we need wise and inspirational leadership to promote good practice for the training required to develop culturally competent practitioners. Thirdly, we all need to develop the habit of cultural competence by using the findings that come out of research and educational projects, most of which are available on the internet. Also, by talking to colleagues and by reflecting regularly on our practice. As I have already mentioned, cultural competence is not about knowing all the customs and practices of the numerous groups that may or may not use our services. It is about having a good deposit of culture generic knowledge which will help us approach our patients with sensitivity. It is about knowing how to ask the right questions that will prevent us from having to say sorry too many times because we offended someone. Lastly, I say to all of you, don't be afraid to challenge cultural values, customs and practices which oppress and harm people. Cultural competence should not be a rigid framework which imprisons our minds and limits our actions. But remember, this requires courage, which is based on wisdom, which comes with experience. Aristotle said that a brave person is not fearless, but one who balances risk wisely. I urge those of you with many years of experience to nurture and support those new to the nursing and other healthcare professions so that they can develop the habits of courage, compassion, and cultural competence.